Good morning. Welcome to this conference on From Current Experiences to Future Opportunities. I would like to give the floor now to Dominique de la Rochefoucauld-Montbel, Grand Hospitaller of the Sovereign Order of Malta.
Thank you very much, Marianne. When just taking off a mask, it reminds for all those who are already here, let's say, how life was 2 years ago. So it's really a pleasure to meet you all here, even if I know that some who should have been here were stuck due to some quarantine. Myself, going normally to Israel in a few days, I was lucky to learn that the quarantine period of 10 days was reduced to 1 day. So that was already good news. Coming back to our subject, Excellencies, ladies and gentlemen, it's with great pleasure that I'm addressing to you today in the frame of our conference, E-Health, From Current Experiences to Future Opportunities. The COVID-19 pandemic has speeded up the use of modern and new technologies and developed others. The aim of our conference is to show the multidisciplined approach needed to a correct use of e-health: moral, political, theological, technical, innovative, scientific, humanitarian. All those aspects must be included and observed. Doctors must be trained, technology has to be installed and developed, and finally, patients must understand to accept it. If you miss just one of these crucial points, the system won't work. E-health encompasses services such as health-related internet information sites, automated online therapy, email consultations, online pharmacies, telehealth, home monitoring systems, virtual clinic. It also includes electronic records, computerized decision support systems, electronic prescribing, and electronic booking for appointments, which has brought profound changes in the organization and delivery of healthcare, as we are going to hear and learn. But first, I would like to give you a short insight of what the Order of Malta is. The Sovereign Order of Malta is one of the oldest institutes of Western and Christian civilization, a lay religious order of the Catholic Church since 1113 and subject of international law. The Sovereign Order of Malta has diplomatic relations with 110 states and the European Union, and has also a permanent observer status in the United Nations Organization. It is neutral, impartial, and apolitical. Today, the Order of Malta is active in 120 countries, caring for people in need through its medical, social, and humanitarian works. Day to day, its broad spectrum of social projects provides a constant support for forgotten or excluded members of society. It is especially involved in helping people living amidst armed conflicts and nature disasters by providing medical assistance, caring for refugees, and distributing medicines and basic equipment for survival. Across the world, the Order of Malta is dedicated to the preservation of human dignity and care of all those, regardless their origin and religion. It operates through over 100 national entities, 133 diplomatic missions concerning 42,000 employees and over 100 members and volunteers, active in about 2,000 medical and social projects within a 10-digit budget. The support provided by the Order always complies with the current norms, national legislation, and largely accepted principle, like the aim to make its participation in health systems sustainable. WHO defines a sustainable healthcare system as a system that improves, maintains, or restores health, while minimizing negative impacts on the environment and leveraging opportunities to restore and to improve it, to the benefit of the health and well-being of current and future generations. For the preparation of other keynote speeches, I got in touch with some of our local professionals in Africa, asking what in their mind is crucial for the sustainability of high-quality healthcare. Of all their answers, showing a recurrent word, cooperation. And exactly, that is what we are trying to start here, bringing the actions together which are central for the good functioning of an ethical use of e-health. Behind sustainability, there's another concept I would like to mention, the difference between ordinary and extraordinary medicine. Ordinary and extraordinary assistance is distinguished by some bioethical theories. Those foundations date back from many centuries ago and have gradually evolved ever. More generally, ordinary measures are those that are based on medication or treatment which are directly available and can be applied without incurring severe pain, costs, and other inconveniences, but which give the patient in question a justified hope for a commensurate improvement in his health. Extraordinary measures are those who are based on medication or treatment which cannot be applied without incurring severe pain, costs, and their application, however, would not give, anyhow, to the patient any justified hope for an improvement of his health. Father James Mcterish, this is a fantastic person. He's a medical surgeon, professor in moral and in bioethics. He's a priest and member of Verbum Dei. And he resumes that before making a decision, he puts forward an acronym, BBC, benefit, burden, and cost. Having said that, over these last 18 months, the pandemic has shown disruptions, unfairness, and unequal access, and especially to tests and vaccines in the case of COVID-19. This should invite us to adapt our approach to changing times, creating new models to preserve sustainability and fairness. And may I resume my intervention by the message I brought to the United Nations Global Summit last December. As in the past, we are not able to rethink and redesign global health, but COVID-19 has forced us now. Transborder operations in bringing synergies together are the key for the end of the pandemic. International and intergovernmental organizations, hand in hand with civil society, have the duty to lead the dialogue and to exchange on achievements in the fight. Knowledge achieved in one country must be shared by all the other countries in the world. Civil society, such as pharmaceutical industry, plus being the pivot of this process, has to apply a humanitarian ethic. My appeal is to improve cooperation, coordination, and joint action on all levels, and it is not acceptable to create a discriminated access not only to the medicine and the care of this pandemic, but in general to healthcare, and may I say, to high, sophisticated e-health. Thank you very much.
And now I'm pleased to give the floor to the Undersecretary of State for Health, Pierpaolo Sileri.
Thank you. So good morning. It's a pleasure to be here, and it's a pleasure to have a meeting in presence, close each other. It's true we still have the mask, but I think the end of this pandemic, I think is very, very, very near thanks to vaccination. So good morning, and let me express my heartfelt thanks to His Excellency, Monsieur Dominique de la Rochefort-Montbel, for promoting this constructive meeting and for inviting me as a representative of the Italian government to contribute to a very sensitive discussion on the challenges and the opportunities of the E-Healt. I'm really honored to have the chance to talk on a topic which comprises several aspects, reflecting the complexity of providing adequate levels of healthcare worldwide through innovation and technologies. I would like to focus on two main concepts highlighted by the title of today's meeting, experiences and opportunities. And I will briefly comment on current practice on telemedicine, both at national and international level, to frame the role of institutions in promoting a full implementation of digital healthcare and to stress how the international cooperation is crucial to guarantee some access to health services all over the world. As this event deliberately occurs in the context of G20, we should not miss the opportunity for a complete and clear discussion on how to better facilitate the widespread of e-health, not just as isolated initiatives, but framed on a shared and solid basis. Undoubtedly, the pandemic is pushing us over the undeniable need of carrying the healthcare right to the patient, putting him/her at the very center of a welfare which should consider the home care as the main setting of assistance. Having the principle in mind, the challenge now is now. Now we need to make the changes, and we need to fill the gaps between the hospital and the territory, between regions and local authorities to ensure equity and uniformity of access to innovation in health services, between different institutions also globally to guarantee adequacy and clinical data. Clinical data are very, very important. Clinical data are important for politicians, are important for administrators, are important for patients. And probably what was missed over the last year and a half was the data collection, the data presentation. Data, and I want to underline this, are very, very important for decision makers. And decision makers are politicians, administrative people, doctors, nurses, industry, and not at the very last hand, but probably at the beginning, to the patient itself. It has been widely stated that COVID-19 has been representing a threshold which forced the national system to change their approach to healthcare. And this same shift of paradigm is now urgent worldwide, not only to respond to cross-border emergency and crisis, but to primarily force a universal minimum level of health offer for each country. Health cannot be considered a single country matter. Health is global. It should be considered global. I think after the G20, the key word was multilateralism. And I think multilateralism for health should be the main way for the future. Health in every aspect is not just the cure. Health means education. Health means research. Health means industry. Health is, I think, the best bridge for the other countries, especially in this century where people are thinking to create walls between countries. I think we need to create bridges to the other countries. And health, with all these the aspects, from education to clinical activities, I think is the best bridge to the other countries. So while national strategies are being deployed for the effective implementation of e-health and telemedicine, as Italy is about to undertake thanks to the significant resources of the National Recovery and Resilience Plan. The appeal is for common policies and intervention that see participation of all actors involved in public health, both in the public and private sectors. As a matter of fact, several pilots of telemedicine in low and middle income countries have been realized during the past years by Italy, but these are due primarily to the efforts of no-profit organizations and the personal support of individual healthcare professionals. As a matter of fact, until 2020, national institutions, even those that regularly deal with international cooperation, had unfortunately never systematically developed health cooperation program based on telemedicine system. However, from the second half of the 2020, a change of direction has somehow been registered. I will briefly recall the experience of the National Center of Telemedicine of the Italian National Institute of Health, the mission of which is conducting, promoting, and coordinating research and system governance for social and health application in the context of new information technology and telemedicine. Last year, the center started the first collaboration with Ecuador. In particular, the Italian National Institute of Health provided a distance training program in Spanish addressed to senior officials of Ecuadorian government and ministries. The lectures focused on the management of health emergency according to the model developed by Italy and described in the dedicated report issued by the National Center of Telemedicine in April 2020. After this experience, the center was involved by a no-profit organization in a project for the implementation of telemedicine services in Brazil to promote this change of good practice by establishing cooperation network to carry out activities for the exchange of experience, training, and medical and non-medical personnel, and the development of a project guide for the creation of replicable telemedicine centers in Pernambuco region in Brazil. Other international experience in health toward developing countries have been conducted directly by some Italian organizations, mainly Catholic communities such as Sant'Egidio. To this regard, telemedicine programs have been implemented in Africa through the creation of teleconsultation, telementoring, telesurgical system within some African medical centers and the dissemination of relative remote training and tutoring programs performed by Italian healthcare professionals. I want to spend a few words on this experience because they should show us the importance of a solid model which must sustain the development of digitalized health system. But this experience should be help much more. I think we need to do more. I mean, we cannot leave to organization or single center this experience and leave them alone. I think the government should help them, financing them mainly. This is one of the main goals for the different national programs and guidelines that have been identified by and outlined by the Italian Minister of Health with the cooperation of the above-mentioned National Center for Telemedicine and the Istituto di Sanità, and by a proper commission for the innovation and digitalization of health services nominated by the ministry. This latter is especially working on the definition of proposal and initiatives regarding the following three main topics: equity and the uniformity of access to innovation in healthcare service, adequacy of processes and organizational model to favor the renewal of health services, adequacy of clinical data interchange tool also by means of artificial intelligence. We are conscious that these are very ambitious goals, and to achieve such target, a lot is still to be done. First and foremost, it is compulsory to guarantee a proper diffusion of broadband and ultra-broadband telecommunication system in all territories in our country. Secondly, the adoption of suitable cloud computing solution and full interoperability of health data must be encouraged, as well as incentive measures and economic support for the updating of the organizational model and procedures to providing health services. The above listed priorities should be considered as the minimal requirements to really implement a health system according to the available resources, both in terms of infrastructure and personnel. I assume you are all aware of the possibility that the National Recovery and Resilience Plan will grant to Italy, with particular regard to digitalization and telemedicine. The key word beneath such investment is proximity. Many resources will be located in order to enhance the integrated home care and to take care of chronicity and the older population, carrying health into a domestic setting. But let me stress out that a central role is definitely played by the adequate offer of training and mentoring towards all the actors involved in providing digital health system, including citizen and patient, who are the recipient of the innovative healthcare. For instance, one major tool which all patients should avail themselves is the electronic health record, which represents the clear connection between national, regional, and social services and citizens. To this regard, the institutions should pose themselves as key actors in ensuring a framework to educate the general public toward national system, raising awareness of rights and opportunities with, which each patient can benefit of is the only way to strengthen and create the trust between citizen and that institution. Thank you.
And now I'm pleased to introduce Elena Bottinelli, who is Head of Innovation, Digitalization and Sustainability of the Gruppo San Donato, with an address on telemedicine and healthcare transformation, a new relation among hospitals and citizens.
Thank you very much for the opportunity of being here to bring our thoughts and experience. So, I think we are all very used to the image above, which was printed in 2019, showing that the growth of the telemedicine market, telemedicine in a broad sense, would raise from 34 billion to 185 billion from 2018 to 2026. This was published in 2019, but what happened with the pandemic has always just changed the figures. So what we are expecting in 2027 is to arrive to 396 billion. So the number of 2026 was doubled. Why that? Because of strong continued uptake. What we have measured in this last year is that telemedicine for visits is now 17% of the total visits, with a spike of 32% that was reached during the pandemic period. We have favorable consumer perception, even if we should address still the perception of technology security. And we have tangible investments of venture capital, digital health investment. So we should say that digital is an unavoidable transformation because of increased consumer willingness to use telehealth, increased provider willingness to use telehealth, and also regulatory changes enabling greater access and reimbursement. This is much more seen in some countries, but it is a trend. So what we have now to think of is we have to move from a bridge to care, that is what we have established in the COVID period, to a new hybrid virtual in-person care model. So this is our aim as hospital managers, but also as institutions. We have the goal to improve healthcare access, outcomes, and affordability. So as Gruppo San Donato, we want to be part of this change. Just to give you a few words about who we are the leading Italian hospital group, private-owned, but working with the state. 19 hospitals, and 3 scientific institutes for research. We call them IRCCS. 16,900 employees, more than 5,000 doctors, almost 5 million patients per year with 5,500 hospital beds. And these are annual procedures, so 13 million annual procedures. So what our mission is to focus on the patient, on innovation and smart services. So this is our chance, and this is why I've been chosen as a manager of hospitals. I've rolled San Raffaele Hospital till July to work on innovation and digitalizations. Our location is mainly in the northern part of Italy. So what we have experienced with telemedicine, televisits, is that we moved from the image on the right, where it was our traditional area from where the patients were coming. So the light regions are the one who have less patients, the darker regions, the one with more patients, coming from all over Italy. And after the introduction of telemedicine, you can see how we have been able to reach more all the country. These are our numbers. As you might see, we have started in March 2020, so with the pandemic starting. And so far, we have for almost 15,000 visits, with more than 1,000 of our physicians part of it. What we have experienced is that these are the top 10 areas the patients are looking for. So psychology and psychiatry is #1, general surgery, general medicine, endocrinology, neurology, cardiology, oncology, hematology, urology, orthopedics. This is what happened to us, but we have also compared this data with what is happening around us, and psychology and psychiatry is really the top one for everybody in the world. What we are doing now is working with McKinsey company to understand better what's happening in order to design what we call a framework which will follow and help the patients to talk with hospitals, with general practitioners, with insurances, in order to have a multi-channel approach, but a very easy approach for the patient. Because what we have, these are what we have found out, that 75% physicians and 60% patients will use digital solution in the next 3 years. 66% patients and 73% physicians believe that access time reduction to care is the best benefit for telehealth. Then we have also understood that 60% of surveyed consumers are now using simple solutions, simple digital solutions as booking and collecting digital records, digital results from the hospital, while a lot of them are still preferring personal visit for high-quality clinical service. Then we have also understood that 50% think that healthcare providers are more reliable than insurances and big tech. So this is why we want to play a role. We see COVID as something which has accelerated the digital transformation, but we think that phygital is the way. So we have to find a way to mix physical and digital. And the best driver is waiting time reduction to access care and the guarantee of clinical excellence. So the objectives of this model we would like to see as a hub-and-spoke model is to expand access to excellency and to specialty care capacity, especially in some areas where there is not this excellency and capacity, and also build a new relation among providers and patients, regardless, of course, of their geographical area. So the benefits for patients is, of course, lower time to access and logistic costs. These have been measured in this last month, also showing that there is sustainability, access, and also we will spare CO2. We can achieve CO2 reduction. So we can also reduce the urgent hospital access. These are some numbers which consultants think may happen. So a reduction of 38% accesses and rehospitalization. And, of course, a length of stay reduction with the possibility to dismiss patients before if you follow them at home. For the physician, the benefit is increase potential of new patients by 2 or 4 times and have easier management of them, both using better the time, but also in order to better follow chronic patients. For the hospitals, of course, this will turn out in a better coverage and access to new patients. Better outcomes, this is something which is very important in digital health, so the opportunity to measure outcomes following the patient along the entire pathway. And, of course, also a redesign of the hospital with hospital space optimization and cost reduction. So the targets and who will benefit more are, of course, long-distance patients, but also fragile patients, caregivers, and the patients who are always in a hurry. And so they want to have a quick response and to and they don't have time for prevention. And of course, telehealth will help them in gaining that. Of course, for the others, especially fragile patients and caregivers, logistic issues and avoiding risk, but also involve the caregiver in the path, is the way. So, but I think we are only in the first step. So we need to digitalize the entire patient journey in healthcare network. So not just alone, but with other providers. Because we have to start from wellness, monitoring lifestyle behaviors. So you are, of course, you know, we have a lot of IoT systems, but we have to understand what we are measuring and to use this in prevention. So, and also helping people in nutrition suggestions, reminders, and understanding better, of course, as I said before, what we are measuring. Then diagnosis, so the possibility for patient to triage, but also and also to help them with symptom checkers. Of course, I believe that the hospital in the back is always the best scenario. Clinical support, so clinical support, speaking about telemedicine, speaking about patient health records, and also the possibility to have a first answer in emergency. Then therapy. So all the opportunity we have trying to follow the patient and to help him to be more adherent to therapy and help him in have what he needs at home with e-prescriptions and home delivery pharmacy or home delivery. Then rehabilitation with the device-assisted rehab, but also with virtual reality technologies that, of course, can help both orthopedic rehabilitation, but also neuro rehabilitation for the patients. Follow-up is very important. Of course, if we want to think of a sustainable health system, we have to measure what we are doing. We have to follow the patient in the time and really ask if we are changing the quality of life of the patients. And so measuring prompts and preempts and having this data utilized and understood is very important. And of course, chronic care and home care services and drugs delivery for chronic patients. So these should be part of the system and of the healthcare network, because I think it is very important to have the different stakeholders on board on this. What are the remaining challenges for what I think is, of course, as it was mentioned, the need for better data integration and improved data flows in the entire ecosystem. There's the possibility of also following privacy issues to integrate and to use the data. The need for better integration of the virtual health-related activities into a day-to-day workflow of clinicians. So as hospitals, we have really to redesign the offer we give and to understand how we can build this hybrid care model. Then we have to promote value-based care instead of fee-for-service mentality. So we think that institutions should really think of systems which promote the value which is created and not pay for the single procedure. Then we have to co-design these pathways with patients. Patients are fundamental in the success of digital and e-health, and so we have to educate, to empower patients, but also to co-design these pathways. And then, of course, the importance of removing infrastructure barriers. We think of internet, storage, but also all is needed really to have the possibility to use this opportunity. Thank you so much.
A digital communication solution to tackle challenges in healthcare around the world. Please welcome Till Berger, Head of Marketing and Communications, Ulm EMEA, and Julia Obstels, Ulm EMEA.
Thanks for the kind introduction. First of all, I want to express my gratitude to His Excellency and the Sovereign Order of Malta for inviting us to this important event. And my colleague Julia Obstels and myself, we are proud to be here. And since we are able and blessed to support medical professionals and improve healthcare around the globe, we are happy to show you our efforts to help those in need. So who are we? We are a healthcare IT company called Ulm, originating from Japan with our HQ located in Tokyo. And following our idea about thinking healthcare in a more networked way, we operate all over the world and have offices in Germany, UAE, Kenya, Chile, Brazil, and the United States. We believe to have a positive impact on healthcare, you first need to understand the specific needs or challenges in respective regions. So having these boats on the ground, having offices around the world, helps us and allows us to adapt our solution to the specific regional needs, and we can support healthcare professionals in the long term and sustainably. The basic idea of helping others is written in our historical tradition. Our communication solution JOIN, the birthplace of our communication solution JOIN, is the famous GK University School of Medicine in Tokyo, an institution founded in the late 19th century, and with one purpose, to help the poor and the suffering. And the GK University is funded and supported by the Royal Japanese family. The connection between our company ALM and the royal family still exists today, since some of our co-founders are members of the medical staff who treats the royal family members. And as I recently learned, there's also a connection, a similar connection, between the Maltese and Japan. Because Konstantin von Brandenstein, a former president of the Malteser Hilfsdienst, is a great-great-grandson of Philipp Franz von Siebold. He was the personal physician to the Japanese emperor in the 19th century. So if I may say that, this is a great opportunity to continue these historic connections of both our organizations and maybe align them to the future. However, we still follow this idea of helping others and have thus won many public projects. We are working closely together with the Japanese government and help governments in other countries to support and improve their healthcare systems. Currently, we are active in more than 30 countries worldwide, and we are proud to say that we work with many key opinion leaders in their respective fields, like stroke, for example, and we support them to implement their ideas and visions of or for better healthcare. For example, we work together with Dr. Jemima Kariuki. She was awarded for her work by the World Health Organization recently. And we also work with Dr. Sheila Martens. She's the current president of the World Stroke Organization. So we are very blessed to work with them. With Dr. Sheila Martens, we also established the first stroke network in Brazil to improve stroke care in the country and make expertise of a few specialists available to smaller hospitals in Brazil. You can see Dr. Sheila Martens in the right upper corner. This picture was taken during her vacation in beautiful Italy, and it's hard to see, but she's looking at a CT scan on her mobile phone. And this picture speaks 1,000 words, because despite she's on another continent, she was able to have access to the medical images in the hospital in Brazil and share her knowledge and her experience to actually help patients in Brazil while she was in Italy. Originally, JOIN was intended for the use in time-critical emergencies like stroke, organ transplant, trauma, or heart attack. But it quickly became apparent that the need for fast and secure communication is important across the whole healthcare environment. And medical professionals started to use JOIN in different scenarios as well, teaching medical students, optimizing the background services, or optimizing aftercare for special patients who need it. So we learned that every medical personnel everywhere on the globe needs to communicate, because medical treatment is always a team effort and communication is key to a successful outcome. And how impactful this communication can be, there's a good example of our stroke network in Sweden. We connected the paramedics with the stroke unit of the Central Hospital in Karlstad. And together and using JOIN, they reduced the door-to-needle time. This is the time from the patient arrives at the hospital until the treatment is done, from 26 minutes to 14 minutes. So they saved 12 minutes, And since time is brain, 12 minutes can make the difference between life or death, or between the independent life or lifelong treatment. So it's a big impact. We have seen great examples of regional networks in Brazil, in Sweden, or in Germany. But we also drive networks cross-continental, as this example of Guatemala and Germany shows. A German specialist, Professor Ringelstein, supports colleagues in Guatemala by reading CT images or other DICOM images and gives them real-time feedback. But helping is just one point of our work. Another important point is to the teaching aspect. We want to train and we want to empower the regional staff to improve healthcare in these regions as well, sustainably. Another great example of such a cross-continental project is the Team Heart in Rwanda. There, the Rwandan docs are connected via join with each other and can share knowledge and experience. But if they need specialized expertise, they can reach out to colleagues in the United States and get feedback from them to actually help and save patients in Rwanda. Building networks and enhancing medical care is an important point, but it's also important to enable access to this care. So we support such kind of projects as well. For example, the network in South Africa, it's a screening program where medical staff goes to remote areas with a special camera, takes images of the eyes, and a specialist in Cape Town, for example, can read these images, give real-time feedback, and arrange further treatment. Thanks to the program, specific diseases can be detected ahead of time and early be treated. So this is good because when you treat the disease before it's starting to grow, that's good for the patient and good for the whole healthcare system, of course. And providing access to medical care is also the goal of Wheels for Life. This is the project by Dr. Jemima Kariuki. I mentioned her before. And she founded a network of different medical providers to ensure medical care for pregnant women or women in labor during the pandemic. So this is a great project as well. And we want to push ahead with these kinds of projects, not only enhance medical care, but also enable access to this care or simplify it. And we are glad to have partners who share this vision with us. For example, the Maltese International. We are in contact with Roland Hansen, and many thanks to him at this point for the great cooperation so far. And hopefully we can start some projects in Kenya or Uganda together soon. We believe that the future of successful healthcare is based on the networking of medical professionals in the hospital, but also outside of the hospital and across sectors and countries. In addition to pure communication, it's also important to be able to exchange relevant information, media, and data fast, secure, and easy. Such healthcare networks are the first step towards a better and more efficient patient care. I will now show you a short video of our project in the city of Essen in Germany, where we connected the paramedics with the stroke unit of the university hospital. And I think the short clips shows the benefits of using Join for both parties and if they are connected.
Join gibt uns eine gute Möglichkeit, relativ früh in diesem Schlaganfallprozess Informationen an alle Beteiligten Gruppen weiterzugeben, ohne dass Tausende von Telefonanrufen notwendig sind, sondern wir haben eine Plattform mit Join, wo automatisch die wichtigsten Informationen wie die Charakteristika des Patienten, auch die Schlaganfallschwere, die Zeitintervalle sozusagen allen zur Verfügung stehen. Wir rollen Join auch als Plattform in den Rettungsdienst aus, in die Feuerwehr. Die Krankenwagen können uns mit Schlaganfallpatienten oder vermuteten Schlaganfällen direkt über Join kontaktieren, uns wichtige Informationen zukommen lassen. Wir können unsere Expertise direkt in die Wohnung der Betroffenen, in den Rettungsdienst zur Verfügung stellen.
Thank you very much. Thank you very much, Till, for the nice presentation and introduction of our company. My name is Julia Obstals. I'm head of operations for Alm EMEA GmbH. And I really like this project from the video you just saw. These are so committed people and a great outcome for the patients. And by the way, this hospital is very close to my hometown in Germany. Okay, but you may ask yourself how we support such different use cases and networks. Alm develops a hub for medical systems and healthcare professionals, and Join is the app, the medical app for your smartphone. Join includes all well-known messaging functions, and I'm pretty sure that most of you have one, maybe also two or more messengers on their private phones. We all used to chat with our friends, we exchange photos with our beloved ones, we send greetings from vacations, we also organize the next birthday present. And during COVID-19 lockdown, we all used video calls to be close to our friends and family, even if we were not able to be with them in person. This benefits of an easy and fast communication should be also available for all of the healthcare system around the world. In medical care, communication is key to tackle healthcare challenges. During times of pandemic or in developing regions, the healthcare workers need secure and safe, but especially easy to implement solution to share medical data and to consult a specialist. With Join, we bring all needed information and consultation and directly to the patient. There's no need for the patients to travel long distances to see a doctor, and there's also no need for the specialists to travel at all. Join brings medical care to those who are in needs just by a tap on a phone. You can download Join from your normal app store or use the Join web link. As we deliver the software, you don't need any specific hardware to join our network. If there's an internet connection, you can use Join even on your private phone. Patients need medical support anywhere and anytime. So do healthcare professionals need access to relevant medical data and consultation anytime and anywhere. Join is not bound to any specific hardware to enable just that. So to treat patients, physicians need, of course, more than just a messenger. To treat a patient, you need access to high-quality data. The integrated DICOM viewer with Join's patented streaming technology enables just that. We can stream complete sets of scans, such as MRI, as you can see, or CT, as you can see here, and ultrasound. Examinations are uploaded to a secure Join cloud in just a few minutes, and they can be shared in a chat group. The patented streaming technology brings us two very big advantages. First, streaming saves crucial time, as data can be reviewed in real time. And second benefit is the data protection, the GDPR aspect. As there's no data downloaded, there's also no data stored on the devices. To upload these exams to the Join cloud, we offer different solutions just to fit the needs of our different users. One possibility is to implement a very small gateway server within the hospital IT network where we upload the DICOM, and from there you can stream it. if there is no IT infrastructure implemented. We also offer our solution on a small laptop to upload examinations from a CD. This laptop can be placed in every clinic, in every small referral site, and you can even carry it with you. So without Join, medical professionals often shared examinations as a single poor quality screenshot which they made with their phones. With Join, patients and physicians experience a huge impact through real-time streaming, and this from complete data sets. And this location independent. Together with our users, we develop more and more medical functions in Join to improve the easy and fast communication. So physicians use functions like patient cases or timestamps very naturally for communication, but at the same time, these functions are provided for documentation. Join provides analytics, insights of clinical and operational workflow, and allows early detection of pain points and optimization possibilities. So you can collect any medical data structured in Join. Yes. As all medical data is streamed and not stored on the device, an organization can trustfully recommend their employees to install Join on their private phones. For us, bring your own device, it's not just a phrase. Oh, this was loud. Okay, Join can be integrated in any already existing hospital IT landscape. We are not just able to stream examinations, we can also stream patient monitors and integrate to a HIS system or digital patient record. On the right side, you can see an integration of a patient monitor from a different vendor. But with all our integration possibilities, we are absolutely vendor independent. We understand that Join needs to integrate easily with all of the already used medical systems inside a clinic. It depends on the use case how deep Join is integrated, and it doesn't depend on the medical systems the hospital is already using. Join brings the platform and the technology to connect medical workers around the world, fast, safe, and secure. You can text about a case, you can share examinations, and of course, use teleconsultation to bring the medical care to those who are in need, no matter where. Our users can rely on all Join functions in a secure and safe environment. Join is, of course, GDPR compliant and CE certificated as a medical device class 1. So our mission is to bring the needed medical informations and the expertise where it's needed. Doesn't matter where or when. Our flexible solution Join enables this also for very rural areas. We don't need any specific hardware, and what makes Join affordable, easy to use, and of course fast implemented. Every healthcare worker with a smartphone can be part of our vision to improve medical care for everybody, everywhere. Yes, in a lot of sub-Saharan countries, many people, especially women and children, have little or even no access to healthcare. And physicians who are on the ground, they serve a large number of people, and yet do not reach those from very rural areas. Here, Join is the solution. One medical caregiver, one nurse with a phone and the Join app can bring their expertise, can bring the specialist directly to the patients, just by a tap on the phone. The world is facing different challenges when it comes to healthcare. But COVID-19 has shown us that healthcare must be thought of globally and should not end at continent borders or country borders. We all have a responsibility for each other. We understood these challenges and we start facing them. So here on my last slide, I just want to introduce you to three very, very nice projects just out of one country. Just one country for an example. And yeah, we are working in Kenya with different partners and institutions on three very great projects in this country. On the upper left side, you can see ICI. It's the International Cancer Institute. And they improve the oncology and palliative care of patients. We implemented JOIN in 13 small clinics, in 13 referral sites in all over Kenya. The physicians now can use JOIN to share ultrasound images or any other medical examinations. ICI is supporting these clinics with their expertise and train them on proper treatment of palliative and oncology care. On the lower left side, this picture is the Medical Training College, and we are very proud to start a project soon with the Medical Training College of Kenya, where JOIN will be used to train and educate the more than 50,000 students. And here, access to real clinical data brings a huge benefit to the training of medical students. JOIN supports many different ways to digitize medical training. And on the right side, finally I want to introduce you to this wonderful project from Dr. Jemima Karaoke. She's a gynecologist and obstetrician and also awarded from WHO 2021 because she's the founder of Reels for Life. Dr. Jemima was experiencing in her clinic many preventable deaths of pregnant women, women in labor, and their newborn children during the peak of COVID-19 in 2021. These women didn't reach the hospital at time due to the fear of COVID, due to the fear to violate the curfew, or they simply just had no access to an ambulance at all. Dr. Jemima established a network out of taxi, ambulances, medical workers, also hospitals to prevent all this. Women in labor can now call a number to receive medical information and also get a free ride to a hospital. JOIN is the solution to triage the patients, so to figure out to which hospital they should go and to bring the informations about the patients already to the hospital before the patient arrives. All this is to prevent unnecessary death of women and their kids So these three very different examples of just one country shows us how improved communication and a powerful network can change the life of a mother and her baby, can improve healthcare, and can even support the future medical specialists in developing countries. Thank you.
Thanks, Julia, for these insights, how JOIN can support healthcare around the globe and help to save patients' lives. We reached the end of our presentation. If you have any questions, feel free to ask me or my colleague Julia. We are happy to help you. And I just want to thank Roland Hansen, Ivo Graziani, His Excellency, and the Sovereign Order of Malta for this great opportunity to be here. And we are looking forward to continue our responsibility and privilege to help others. And maybe together we can save more lives. Thank you.
Thank you very much. And now we would like to invite you for a cup of coffee on the floor below. Thanks. I would now like to welcome Janine Leitmeyer, Head of Regional Department Middle East, Maltese International, who will talk about digital health in humanitarian emergencies, and in particular the digitalization of mobile medical units in Lebanon, and her colleagues Babak Miremadi and Edmund Lebrun, who are not able to be here today because they are on quarantine, but they have sent a video. So we will have their contribution too.
Excellencies, ladies and gentlemen, thank you very much for this opportunity to be here. It has been a very interesting morning already for me, with a lot of learning. Maltese International, we're the worldwide humanitarian relief agency of the Order of Malta. Our mandate is to provide relief and recovery services. We have more than 100 projects all around the globe in more than 20 projects. And I'm happy and humbled to be able to contribute to the mission of the Order to serve the poor and the sick. I'm being responsible for the projects that the Order is implementing in the Middle East. I would like to invite you to meet two of very important persons that I've met during our travels. These are two little girls which I've met during my travel to the region, and those two girls have a lot in common. They're both born in a situation where it's very difficult to raise children because they're both born to families who live in displacement. One in northwest Syria and one in Lebanon. The two girls face a situation of distress and look at the perspective of a life in poverty, maybe. Both are Syrians, but don't have a birth certificate of the state they were born to. So both will probably struggle together with the families with the deprivations of a life as a refugee. But the good news is both girls, thanks to the Order of Malta, profit from access to free basic health care. They both see a pediatrician regularly. And now we come to the topic of today's discussion, because what's very, very special about those girls, both have a digital patient record, which sounds a bit particular, and which it is, and I'm happy to give a bit of an insight together with the company you're going to meet, at least in a video that they provided, because what the Order of Malta in a joint venture did in Lebanon is, and I love this term that I learned this morning, going phygital in a way. So this is a mobile medical unit that the Lebanese Association of the Order of Malta kind of invented as a reaction to the refugee crisis in Lebanon, where every fifth citizen of a very tiny country is a refugee, and the healthcare system from the beginning of the Syrian crisis has been overwhelmed with the influx and the demands that such a huge increase in population puts on a health system. So the Order of Malta in Lebanon is running a network of basic healthcare centers. And in addition to the fixed centers providing primary health care, they came up with this crisis response mechanism to have a bus fully equipped as a mobile medical physician center. So the bus has 2 rooms, and as you can see on the picture, they're receiving patients. Most of the patients are from the Syrian refugee community. With the situation in Lebanon as it is now, we're seeing more and more Lebanese patients being in need of the same services. And as you can see on the second picture, and this is the pilot project we would like to share our experience today, is the social worker that accompanies the physicians and nurses in the mobile unit and is taking the patient records. This was done on paper, which as you can imagine, post a huge load in a very tiny clinic. And this has been digitized thanks to the fabulous intervention of Elephant Healthcare. And I would like to hand over, at least virtually, to the colleague Edmund Lebrun, who will now present you the pilot that we did as a joint venture in those clinics in Lebanon.
Hello, everyone. It's an honor to be with you here today virtually, although great shame that I'm not with you in person. My plans were unfortunately scuppered by COVID restrictions, and I'm currently stuck in Morocco. But it's an honor nonetheless, particularly to talk about this wonderful partnership between ourselves and Maltese International. Elephant Healthcare is a British health technology company that was founded in 2018 by two British doctors. And our work together with Maltese International in Lebanon was very much a springboard for ourselves as a company, and we've since grown significantly since. And so it's a wonderful opportunity to speak about this early partnership, and it's also a great opportunity to reflect on how very lightweight, scalable technology can be deployed in some of the world's most challenging health contexts. And what we learned in Lebanon was how such technology could be deployed, particularly in crisis settings, to enormous effect. And so that's what this talk will largely be about. So in 2018, what was the situation we found ourselves in, and why did we start speaking to Maltese International? Well, Janine will have given some of the background, but to give some more, Maltese International were seeing roughly 40,000 patients a year in northern Lebanon, in this region called Akkar. And there, 95% of the population they were treating was from refugee communities, from Syrian refugees who had crossed over into Lebanon, often living in UNHCR settlements or in informal settlements, many of whom living below the poverty line, and a large number with very complex medical needs. There's a figure there of 20% of those who required hospitalization were simply not being admitted to hospital due to questions of cost. And so this was the scene into which we were entering. It was an area of limited resources with complex medical needs, and a paper-based medical record system. So Elephant did a piece of research looking at what the needs were and how technology could be used to help make a difference in this context. And so the first thing that this research uncovered was how much pain was being caused by the paper-based record system. The first and most obvious way this pain was being caused was the enormous drain on time that was associated with paper records. So up to 5 hours per day was spent on administrative times related to paper. And that included an hour at the beginning of the day where all the paper medical records were prepared for the mobile medical unit to then be taken with the mobile medical unit throughout the day as they were seeing patients. 3 hours where those paper records would then be transcribed into the reporting system at the end of the day, which is not a job that anyone particularly relished or looked forward to. And then 20 minutes per patient where, and you have to imagine these are extremely time-pressured, chaotic, difficult environments where every minute is of the essence. And this 20 minutes was being taken to often find paper medical records for the patient the doctor was seeing at that time. So there's a huge time drain. The second factor was the logistics complications. First, most basically, the nurses who are often doing the moving around of these paper records were having to lug 4 to 5 large boxes full of paper medical records around with them, which was extremely physically demanding. And then because of the way that the mobile medical units operated, the paper files were prepared for that day and loaded onto the van. Was what often happened with patients is that they would know the mobile medical unit was coming, and they would travel from another village to go to that to see the doctors. But because they came from outside of the intended catchment area, their records were missing, and that patient would struggle to have the continuity of care they needed. And all of these records were taking up vital space in these mobile medical units where every single inch was important. The third kind of impact that we witnessed was that with paper medical records, it was very hard for doctors to navigate the notes quickly to see the important clinical information, read the patient's story, and understand what their medical background was, which is crucially important when doctors only have a very limited amount of time to see each patient. They were spending 3 minutes per patient. And so when you've got a large chunk of that time looking through the notes, trying to understand what their medical history is, that's a crucial amount of time as well. A lot of, when you're transcribing notes by hand, especially at the end of the day, as was taking place, that's very vulnerable to error as well. And so a lot of mistakes were being made in the transcription, and that was really affecting the quality of care patients were receiving. And then lastly, because of this system, it's very difficult for management and Malteser to have good information on key health metrics. What was the number of diseases in this specific area? What was the costs of delivering this healthcare? What was the impact of delivering this healthcare? And if there was a disease outbreak like with COVID-19, for instance, it'd be very hard to nimbly respond and adapt the form of care patients were receiving as a result. And that leads on to the second point of accountability. In crisis settings, it's particularly important for donors to understand where their money is being spent and what it's going towards. And without high quality, accurate data, it's very difficult for them to report on that. So the technology that we're proposing was a direct response to that demand for accountability, making sure that donors and health leaders knew exactly what these mobile medical units were delivering, what they were achieving, and what impact they were having. And lastly, security. When you've got boxes of medical files tossing around the back of a van, however well looked after they are, it's very easy for them to become lost, damaged, and even stolen. Health data is some of the most valuable and sensitive data there is. And so it's extremely important that it's kept safe. And it's much easier to do that on a secure cloud-based system than it is when you have cardboard boxes full of data. So Elephant came up with a solution which had 3 core elements to it. And although these different elements have evolved a lot since 2018, they remain fundamental to our work. So the first thing was a health ID. This is a portable physical card, size of a credit card, with a QR code on it. And every time a patient would come to the mobile medical unit, they were given one of these cards, they were scanned, and the doctor and the clinician would take their clinic notes on their system that was attached to this physical card. So the idea is that the refugee or whoever the patient is, whenever they're turning up a system with elephant on it, they'd simply scan the card and the doctor has access to their full file. The second thing is this operating system. So in this project, we simply had clinical notes. So this was the system that all doctors were using to take up notes and to issue prescriptions. Our operating system has now advanced. It has medicine stock management, it has invoicing, it has insurance integrations, etc. But back then it was simply just clinical notes. And this was designed in such a way that it was extremely easy to type up notes and organized in such an order so that you could see the key pieces of information directly. And so doctors would be able to glean from whatever patient record they were seeing the key information immediately. The third element was analytics. So all of this high quality, high fidelity data was being pulled in live to analytic dashboards, which enabled Maltese International and other health leaders to zoom in, zoom out, and get at whatever health information they needed. So that's everything from rates of disease through to the type of medicines being prescribed, to the waiting time that it takes between a patient arriving at the clinic and a patient seeing a doctor, to a patient going to the pharmacy to picking up the drugs. So it was tracking every single piece of key data. And with those high-powered analytics, health leaders have the tools to be able to make decisions very quickly. So there are these three core elements. And when we're designing this, we like to think about it like Lego for healthcare. And why do we think of Lego? Well, we think of 4 characteristics when we think of Lego. And these are essential to our thinking still today. First is that it's extremely easy to use, it's intuitive to use. And that's very important for doctors working on the front line who have been used to paper records, used to paper recording systems, and who might not be so excited about the idea of technology or not be familiar with it. So it's got to be extremely easy to use. It's also got to be easy for patients to use. They've just got this simple card that they carry with them wherever they go. There's nothing more complicated than that. It's also got to be enjoyable to use, because old habits die hard. And if the clinicians were not enjoying using it, they didn't perceive it to be making their lives any better, they would simply go back to paper records. And software is only as good as the people, the data that's inputted into it. So if people weren't using the software properly, it wouldn't be effective. So it is really crucial that it's enjoyable and straightforward to use. Third is that it's lightweight. So often in crisis situations, there isn't good internet connectivity, and that is crucial. So the system was designed so that it could work on just a 2G edge network. That's it. So extremely lightweight, and that enabled it to run on incredibly low connectivity, which is crucial. And then the fourth element, of course, about Lego is that it's all connected. So these are modules that you can all connect together. And when you connect these core elements of care together, patient records, clinical notes, analytics, the way the money flows in the system, you start to be able to make decisions where you boost efficiency, you boost the quality of care patients are getting. So what was the kind of the impact of this? Well, a lot of the impact was kind of as we expected, so as kind of laid out in the problems that we identified. So in terms of time, following the introduction of the system, 3 hours were slashed off the day of the medical staff in transcribing patient notes. So it's an enormous saving of time. In terms of the actual seeing the patients themselves, it went from 3 minutes per doctor appointment with the patient to 2.8 minutes. So that was a narrow, it did save time, but it was narrow. But the crucial thing is what was happening in that time with that patient. And doctors were spending less time noting and more time actually concentrating on the patient's needs. So that was a crucial change. Second thing is care. The first obvious thing that was the improvement is suddenly patients, often for the first time, had continuous access to their medical history. And that allowed them to get continuity of care wherever they go, whether you're a refugee or whether you're a settled citizen. This is extremely important in ensuring the patient gets the quality of care they need. And thirdly, suddenly, with full visibility on all of this data, health leaders could, they have the information they need to be able to measure their impact and adjust the way in which care is delivered in real time. All of this data is being pulled into the cloud live. And so, again, to take the COVID-19 example, although it's true of any disease outbreak, whether it's cholera or polio or whatever, seeing exactly what these cases are, where they're coming, in what frequency, all of that is crucial for health leaders to be nimble, take quick actions to help control these disease outbreaks. And so that was transformational. And I think for Maltese International, extremely important to show donors where their money is going, how it's being spent, and how many patients were being seen. One example is, I mentioned that 40,000 figure at the beginning. That was the sense that that was a feel for how many patients we're seeing, and it was also recorded in these paper records. But having implemented the system, it seemed like actually there were fewer patients being seen, and there was a lot of duplication in paper records, etc., was leading to these skewed numbers. So with this accurate data, suddenly impact could be measured and more effectively. And then there were some unexpected benefits, or benefits which were less immediately obvious. First thing is that clinicians all reported having more headspace, so more time and space to concentrate on patient needs. There was less chaos in clinics. You can imagine when you're seeing 3 patients, a patient every 3 minutes, and you're surrounded by paperwork and the typical clamor of delivering primary healthcare. It's quite hard to give a patient their full concentration. And just by stripping away some of that chaos and introducing some calm, efficient, controlled order that came through the technology, it was able to improve the way that clinicians were able to deliver care. So that these are subtle but extremely important changes. And then for users themselves, one of the things we're surprised about is that the patients really hung on to their cards. There's a 98% retention rate with the cards, which means that 98 out of 100 people, when they would come back to the clinic for a second time, still had their card. And so that showed us, A, that patients understood the value of card and understood the importance of keeping it. But it also, in interviews with patients, we're surprised at how much they appreciated not having to remember what treatments they had had in the past, what medications they had been prescribed. And this was often a source of anxiety for patients going into those, when going to see a doctor. And so all of that was removed. And so it's a much more enjoyable experience for patients as well as doctors. And then we saw waiting times between arriving at a clinic and seeing a doctor massively slashed as well, because of the efficiency of scanning the card, getting the patient record straight away, instead of the the experience that happened before of turning up and then it would take up to 20 minutes to then find their file. So for us, this is what we learned in Lebanon has informed everything that we do. Still, that Lego for healthcare idea is central to what we're doing. That it's easy to use, that it's lightweight, that it's connected. These are all things that we've carried through our work, and we're now partnered with governments in 3 different countries, and partnered with NGOs and many private providers as well. And what this is kind of evolved into is a lightweight digital infrastructure upon which all other parts of a healthcare system are built, and which are fully integrated in one system. So that's not just patient records, but it's stock management, it's payments, it's insurance, and it's all the clinical modules doctors need to do their work. And by joining up all of these elements, we're starting to see governments experiencing huge efficiencies, cost savings, and quality improvements in healthcare delivery. And so it's been crucial. I think learning these lessons in a crisis situation where the demands are very, very, very tough, kind of helped us develop a discipline when building this technology, which has made it a lightweight technology which can be rapidly deployed pretty much anywhere in the world. And so whether it's a crisis situation or a settled situation, actually often the needs are the same, but the deployment still must be simple, effective, and easy to use. And so we very much carry forward those lessons with us. It was also the beginning very much for Maltese International and realizing the importance of digital healthcare. So I'll just pause there to let Janine continue. But as this is a recorded session, I'll say goodbye now, and thank you very much for having me.
Thank you. So the journey that Edmund just described was a pilot for MI, and we were not alone in this. We had a good partnership, but also what's important to mention, we need, and that's why I'm so grateful for this opportunity on a conference, you need to bring together a lot of stakeholders. So our project was financed by the German government, who believed in that we can go with a pilot like this and that it will have the impact, which we didn't know at the beginning of the journey, but which was quite a finding for us and for them, and puts their mind at ease, as Edmund mentioned, regarding the money, how it's spent, because it gives us evidence and confidence in that we can do it. And it also helps us taking blueprints of the things that went well. I'm happy to report that the clinics in Lebanon nowadays have the same digital system, but it's run and implemented by the Ministry of Health of Lebanon. That's the way we want things to be, because we as humanitarians are gap fillers. We shouldn't be the major providers. But it helped a lot that the Order of Malta in Lebanon was able to prove it's possible to do it even in a setting which is unstable. The huge advantage of an organization like the Order of Malta, combining tradition with maybe a little sense of adventure and an appetite for innovations, also that often we're more flexible than a bureaucratic system that doesn't allow. That's our daily bread and butter. We need to be flexible, and we can go forward with things where other institutions or organizations might struggle more. If you have to serve a huge number of hospitals, the time to convince people of a digital solution might be longer. So this is the positive impact of that. I'm happy to report that we try to replicate the same system, being very specific on the needs on the ground. But what you can see here is a visit that I did with the new Secretary of General Clemens Milbach in the beginning of this year to Syria, where in the primary health care center, They also implemented a digital health system, which is not the same as Elephant, but basic features are the same. The patients receive a QR code, the patients have a digital health record, which is enormously helping to have the efficiency, but also the transparency in settings where it's not easy to have access, and where the organizations running health institutions have a huge pressure on proving that what they're doing is the right thing in a certain setting. So thank you very much. I'll be happy to answer any questions after the session, and thanks for having me.
I am now pleased to introduce from the Republic of Benin, the Minister of Health, Benjamin Hunkpatin, who is connected in streaming to this conference.
Est-ce que vous me recevez? Est-ce que vous voyez l'écran?
Yes, Minister, we can hear you very well.
D'accord. Malheureusement, la présentation n'est pas traduite en anglais. J'espère que ça ne vous dérange pas. Je vais présenter lentement.
Oui, merci. Vous pouvez continuer.
D'accord. Okay. Je voudrais encore une fois vous remercier pour cette opportunité de vous présenter ce que nous sommes en train de faire en République du Bénin par rapport à la télémédecine, dans un Bénin où nous sommes en plein dans la réforme du système de santé. Alors, je vais vous présenter rapidement un peu les réformes que nous sommes en train de faire déjà et la pratique que nous faisons actuellement dans le domaine de la télémédecine au Bénin et les besoins ultérieurs ou d'actualité en matière de télémédecine ainsi que les défis organisationnels que nous avons. Vous savez, le Bénin est un pays qui est situé dans l'Afrique occidentale, justement ici, juste à côté du Nigeria. C'est un pays qui a une superficie de 114 763 km² avec 12 départements, 77 communes, 546 arrondissements. Alors, nous avons pratiquement, depuis notre indépendance, nous avons actuellement pratiquement 12 millions d'habitants et au niveau de notre pyramide des âges, comme vous avez pu le constater, c'est une structuration pyramidale, vraiment avec une population très jeune et qui est là dans le pays. Et notre organisation au niveau du système de santé est une organisation structurée de façon un peu pyramidale. Nous avons au niveau national les hôpitaux nationaux et puis après, au niveau des 12 départements que nous avons des centres hospitaliers départementaux et au niveau des départements, nous avons des hôpitaux de zone. Chaque département est divisé en zones sanitaires, nous en avons 36 et puis nous avons des centres de santé périphériques, au total 901 centres de santé périphériques. Donc, pratiquement 4 niveaux de structuration au niveau de notre pyramide sanitaire. Alors, nous avons entamé depuis bientôt 5 ans des réformes au niveau du système de santé pour assurer une meilleure accessibilité de la population aux services de soins de qualité, une meilleure disponibilité des praticiens, une amélioration du plateau technique avec évidemment en sous-bassement une réhabilitation et une construction de nouveaux hôpitaux et la médicalisation progressive de toutes les formations sanitaires périphériques afin globalement de pouvoir arriver à assurer la meilleure qualité des soins, l'amélioration de la sécurité des patients, ainsi que la réduction des évacuations sanitaires. Je dois vous dire que les évacuations sanitaires coûtent en moyenne au pays pratiquement 10 milliards de francs CFA par an. Ça va correspondre je suis en train de voir, de faire l'exercice en dollars, pratiquement 2 millions de dollars. 200 millions de dollars, je pense bien, si je ne me trompe pas. Alors, nous sommes en train actuellement de structurer une nouvelle carte sanitaire et avec l'institution d'une couverture sanitaire universelle, la mise en place de nouveaux modèles de motivation du personnel et le développement de nouveaux pôles de compétences. Vous comprenez aisément que par rapport à tous ces défis, surtout avec le développement des nouveaux pôles de compétences et la médicalisation des structures sanitaires périphériques, le développement de la télémédecine devient une obligation pour nous parce que nous n'avons pas forcément le nombre de médecins qu'il faut pour couvrir l'ensemble du territoire et l'ensemble des structures sanitaires. Le développement de la télémédecine sera d'un grand atout pour nous, pour les différents pôles de compétences que nous sommes en train de développer, notamment en matière d'urgence, de cardiologie interventionnelle, de traumatologie et d'orthopédie, d'oncologie, de chirurgie cardiaque, de neurochirurgie, de médecine préhospitalière, mais également de l'anatomopathologie pour poser, confirmer les diagnostics par rapport aux pathologies cancéreuses. Quelle est l'expérience que nous avons déjà eue en matière de télémédecine au Bénin? Nous avons eu une courte expérience en 2004 grâce à la coopération avec du centre de dépistage et de traitement de l'UCL de Burulia à Lada, avec une équipe italienne en télépathologie avec des images histologiques qui étaient interprétées. Nous avons également, au niveau de l'hôpital de Tanguieta et des frères Saint-Jean-de-Dieu, une bonne collaboration également avec la télémédecine qui est mise en place avec une équipe italienne toujours. Au niveau de l'hôpital départemental de Lokossa, ça c'est dans le sud-ouest du pays, nous avons développé avec une équipe chinoise également la télémédecine avec la réussite d'au moins 5 interventions entre la Chine et le Bénin, des interventions avec une équipe sur place qui est accompagnée par une équipe chinoise qui est basée en Chine. Et nous avons l'expérience que nous menons également au niveau du CNHU, le plus grand centre de référence du pays, qui est en partenariat avec une expérience qui est faite avec l'Inde. En dehors de ça, nous avons des startups au niveau du Bénin qui ont développé des applications qui aujourd'hui permettent de la téléconsultation. Il s'agit de Go Medical, d'AlloDoc, de D-Doc, de Medom, qui sont aujourd'hui en pleine expansion au niveau du pays. Nous avons également un développement d'une application mobile de suivi personnalisé, préventif et informatif à destination des usagers avec un autre logiciel, Drepacar, pour les malades qui souffrent de la drépanocytose. Ainsi donc, par rapport vraiment à la structuration, comme je vous l'ai dit, nous avons des centres hospitaliers départementaux autour desquels flottent des hôpitaux de zone qui sont les niveaux de première référence. Nous avons en ambition de développer aussi bien la téléconsultation, la téléexpertise, la télésurveillance et la téléassistance. En matière de téléconsultation, c'est pour pouvoir vraiment offrir des consultations aux populations vivant dans les zones périphériques où les centres ne sont pas encore médicalisés. Ainsi, les infirmiers qui sont en périphérie peuvent examiner les patients et communiquer avec le médecin qui est au niveau de l'hôpital de zone ou bien du centre hospitalier départemental pour pouvoir avoir un diagnostic précis et instituer le traitement adapté. En matière de téléexpertise, nous envisageons et nous ambitionnons donc d'apporter une expertise aux hôpitaux des hôpitaux de zone au centre périphérique, mais des centres hospitaliers départementaux également aux hôpitaux de zone ou entre centres hospitaliers départementaux ou centres de niveau national. Nous sommes en train de faire aujourd'hui le développement de la cancérologie et il est évident que nous n'avons pas toutes les expertises qui sont concentrées à un seul centre. Et c'est pour ça que nous avons nous avons développé la téléexpertise pour que les réunions de concertation pluridisciplinaires, qui sont une obligation en matière d'oncologie, puissent s'organiser, même avec des équipes au-delà même du Bénin. En matière de télésurveillance, nous ambitionnons de monitorer à distance les données cliniques et imagerie biologique des patients, étant entendu que nous n'avons pas toujours l'expertise nécessaire pour avoir les ressources humaines sur place. Et enfin, la téléassistance pour donner un avis médical ou participer à une intervention d'un centre plus expérimenté vers un nouveau pôle de compétences. Nous avons évidemment dans tout cet environnement que nous avons développé, que nous avons déjà commencé à développer petitement, de véritables défis qui sont surtout organisationnels. Le premier défi, c'est la pénétrance de la connexion Internet à haut débit sur toute l'étendue du territoire. Actuellement, ce n'est pas encore une réalité, mais avec le ministère du numérique et de la digitalisation et les agences du gouvernement qui interviennent, nous sommes en train de faire en sorte d'améliorer la connectivité Internet à haut débit, au moins entre les hôpitaux départementaux et les hôpitaux de zone déjà. Nous avons également la problématique de la qualité et de la stabilité de la connexion Internet, la formation du personnel médical et paramédical qui aujourd'hui peut également se faire grâce à cet apport de la télémédecine, la sécurité des données des patients dans cet univers où nous allons digitaliser tout et le secret médical, si nous ne faisons pas attention, pourrait être exposé. Et là, les données des patients pourraient être également exposées, ce qui donne un défi sécuritaire par rapport à ces données. Il y a le respect du code de déontologie dans cet environnement où nous allons pratiquer la télémédecine, parce que c'est très important que nous puissions continuer à respecter vraiment les bases essentielles du code de déontologie dans cet environnement. Il y a les méthodes et modes de tarification des actes. Combien va coûter aujourd'hui une téléconsultation? Combien va coûter une interprétation d'un examen qui est fait par la télémédecine? Et évidemment, dans tout cet environnement, il faut qu'on puisse maîtriser le contrôle des pratiques médicales. Autant de défis qui s'imposent à nous dans cet environnement où nous avons aujourd'hui, évidemment, le développement de la télémédecine. Mais il est évident que la télémédecine est aujourd'hui incontournable, surtout avec l'avènement de la COVID. La COVID nous a imposé littéralement d'avoir recours à la télémédecine pour pouvoir avancer, pour pouvoir mieux travailler face aux défis du respect des distances de sécurité sanitaire, des règles qui ont été imposées lors de l'avènement de la COVID. En conclusion, je voudrais dire que la pratique de la télémédecine dans un monde en perpétuelle évolution, avec l'avènement de la COVID-19, qui oblige au distanciel, dans un Bénin en pleine mutation, s'impose à nous, à l'heure des réformes en santé que nous sommes en train de faire actuellement pour une meilleure sécurité et une meilleure qualité des soins à nos patients. Je vous remercie de votre attention et je vous remercie encore pour cette opportunité de m'exprimer sur ce sujet. Merci.
I would now like to give the floor to Giovanni Ferrigo, who is CEO of Inuit.
Okay, first of all, I would like to thank the Grand Hospitalier of Sovereign Order of Malta for invitation and all the participants. Inuit is an Italian company, is the biggest tower co in Italy. It's quoted in Milan Stock Exchange. Our mission is to facilitate, to support all the mobile operators to roll out their network, in this day, the 5G, for example. And we are very specialized in the indoor coverage. The last example that I can mention is we cover the Nuvola for the G20 event in indoor to permit to the participants to have excellent mobile connection. So, okay. As many of previous speech said, it's impossible to ignore the role of digitalization as a crucial opportunity for moving towards a new paradigm that looks to technologies as a tool to build a green, resilient, this is a word very important that as many times mentioned, and future-proof society. Bringing together technological innovation and sustainability, designing better societies and economies is the main challenge that in this moment we are facing in this historical phase. Towards today, we are all more aware that the digital is the greatest ally of sustainability, and that can be no sustainability, economical, environmental, social, without digital technologies. In this perspective, the 2019 JESI study identified the 7 most impactful digital technologies for achieving the 17 sustainability goals defined by the United Nations, as you see in the slide. The digital transition is a complex process of change combining the horizontal and diffuse nature of general-purpose technologies with the vertical development of new and specific sectorial use cases relevant for sustainability. In particular, sorry, there is some numbers. I am an engineer, no one is perfect, but some numbers, I use numbers, okay? You can read the results of the Digital Innovation in Healthcare Observatory of Polytechnico of Milan School of Management, where there is let me say, a picture of, let me say, what is happening with artificial intelligence. The pandemic pushed the development of digital health towards a connected care model in which digital technologies are fundamental tools to achieve a new form of healthcare based on sustainability and close to citizen needs. Just this sector, let me say, the spread of digital tools in the healthcare sector also improving their knowledge and use. In 2020, national spending on digital health increased by 5% compared to 2019, reaching a total value of 1.5 million euros, about 25 euros for citizens, more than 1.2% of Italian public health spending. There is a widespread awareness among doctors of benefits of digitalization, in particular regarding artificial intelligence in the healthcare sector. You can see the results of this, let me say, study. Moreover, today, the development of the telemedicine finally became a key element in digital health policies. Decision makers and stakeholders understood that telemedicine is fundamental to guarantee continuity of care and integration between hospital and territory. In the last month, the use of telemedicine application by doctors increased a lot in Italy. Before the pandemic, always an engineer, sorry, but just 10% of doctors used telemedicine, while during the emergency, more than 30% started to adopt many telemedicine applications. The most used telemedicine service is teleconsultation, with 47% of specialists and 39% of general practitioners using it, attracting the interest of 8 doctors out of 10. Then there is a televisit used by 39% of specialists and GPs, and telemonitoring used by 28% of specialists and 43% of GPs. Anyway, these solutions are still little used by patients, not for a lack of interest, but for the limited offer. The telephone or video call to check in with the doctor is still the most used modality for remote monitoring, adopted by 23% of patients, while the use of structured telemedicine services, that's just a little different, such as a remote visit with a specialist, 8% of patients, remote rehabilitation, 6% of patients, remote monitoring of clinical parameters, 4%, is still marginal, although there are solutions of great interest among patients. considering the actual estimations of specialist doctor on remote visit, 20% about of the doctors, and patients with chronic disease, 24 million of us in Italy. The digital innovation and in healthcare observatory estimate that thanks to the enhancement of the telemedicine services, it will be possible to save 48 million of hours currently wasted for travels that can increase to 66 million hours if we consider that the 35% of the patients are accompanied by caregivers. This is a total engineering slide. Okay, just to comment. Today, this is the process of digitalization of health system in Italy is still fragmented and uneven, with only 3% of visits by specialist doctor with chronic patients that took place digitally in 2019. In particular, this is the point. One of the most critical points is digital skill of health professionals, which are currently insufficient for new trends of technological revolution. Although 60% of medical specialists and general practitioners are sufficient digital literacy related to the use of digital tools, only 4% have a satisfactory level of skills in all areas of professional digital competencies, the so-called E-Healt competencies. For this reason, today it's fundamental to develop best practices already used in Italy and at the same time spread appropriate skills. Just Mrs. Bottinelli commented this. There are 3 examples. There are the remote diagnostics. This is some example of innovative of these services. And there is this is the real example that we develop with some, let me say, companies. The televisit and the telerehabilitation. This is very important. That is very, very, let me say, useful. Well, so we can say that artificial intelligence will also bring benefits to healthcare systems, automating not only the health team, but administrative tasks and supporting doctor decision-making processes. Moreover, the algorithm used in artificial intelligence system will play a relevant role in medical profession, representing an added value to medical expertise. According to estimates provided by Humanitas University of Milan, the value of global artificial intelligence market will grow from $3.9 million to 28 million in 2025. Through this solution, the patient will be more actively involved in treatment and rehabilitation processes, with many benefits on patients' observation in respect of the treatment plan and saving expenses and time. Oh, in this context, we are in incredible days. Why? National Recovery and Resilience Plan will have a key role for supporting healthcare innovation. In particular, the NRRP Health Mission included investments for more than 20 billion euros divided into very important components: the proximity networks, facilities, and telemedicine for territorial healthcare, with a total amount of 9 billion euros, included 4 billion euros for home as the first place of care and telemedicine project, with 1 billion euros specifically dedicated to developing programs enabling remote doctor-patient interaction, in particular diagnostic and monitoring. The second component is focused in innovation, research, and digitalization of NHS, with a total amount of about 11 billion euros on development of technical, professional, digital, and managerial skill of health system personnel. In order to reach a real step change of health sector, spreading through the country innovative solution, improving efficiency and effectiveness of healthcare service, development of 5G enable all new technologies as augmented reality, artificial intelligence, and Internet of Things, which will be fundamental for developing the new healthcare paradigm. Only deploying ultra-fast network in all in the Italian territory, including rural areas, it will be possible to overcome fragmentation of healthcare levels, ensuring continuity of care regardless of place where a patient is, and improving the quality of life, not only of patients in hospital, but of all people suffering from disease and forced at home. But to fully exploit the potential of 5G revolution, it's fundamental to support fifth-generation networks' widespread coverage, not only outdoor, with the TLC towers, but also inside all strategic places, hospitals, stations, airports, museums, industries, universities. We have an example for each one of these branches. This will be possible thanks to DAS, distributed antenna system, or small cell, which are perfect solution to cover areas very crowded or with reception problems. INWIT has always committed to build a smart Italy, where digital technology can truly represent an opportunity for a better and more inclusive country, where advanced services, innovation, sustainability, and attention to the needs of citizens and territories are milestones for a new deployment model. With this objective, INWIT updated 2021-2023 business plan foresees an investment program of around 600 million euros, aimed at building new towers and developing indoor and outdoor micro coverage with DAS or small cell solution. In particular, regarding the health sector, since the start of the pandemic, INWIT already signed agreement with more 30 hospitals for coverage with DAS microantennas, reaching a potential area of 9 million of citizens and more than 16,000 beds. Thanks to this infrastructure, healthcare facilities can benefit from a stable and fast connection to main mobile networks at maximum performance, even in closed environments where the signal hardly arrives in normal conditions. Moreover, the commitment to greater sustainability has also been a key element for INWIT, both in its role as enabler of innovative solutions and within the company itself. For this reason, we recently adopted 2021-2023 sustainability plan with the precise objective for the next 5 years, in line with the United Nations 2030 agenda. The plan foresees carbon neutrality by 2025, purchase of 100% of electricity for renewable sources by 2022, and investment to overcome digital divide and gender gap. Okay. Finally, INWIT directly contributes to achievement on SDG 11 in sustainability, cities and community, which aims to make cities inclusive, safe and sustainable, and SDG 9 for industry, innovation and infrastructure, whose goal is to build a resilient infrastructure and promote innovation, and responsible and sustainable industrialization. In conclusion, the pandemic highlighted the importance of digital technology in making our healthcare system more sustainable, effective and resilient. Today, we have a great opportunity, thanks to NRRP resources, to overcome fragilities that emerged during the healthcare crisis and start building a new healthcare paradigm. This will be possible using digital technology to promote more effective collaboration between all the players in healthcare ecosystem and model healthcare services on the needs of citizen patients. This is a necessary revolution that can be achieved only investing in digital infrastructures in one side, and then the other, developing a new digital culture among citizens, health professionals, and patients. Thank you.
Thank you very much. And now I have the honor of inviting Monsignor Vincenzo Paglia della Pontificia Accademia per la Vita.
Eccellenza Grande Ospedaliere, amiche, amici, io ringrazio dell'invito che mi è stato rivolto a questo convegno. Per parte mia, il tema che vorrei svolgere riguarda tecnologie e fine della vita, il primato dell'accompagnamento. Dico questo anche perché, non essendo un ingegnere, guardo più all'accompagnamento che ai numeri, non perché non siano importanti. Ci troviamo di fronte a un tema che è particolarmente delicato. Come loro sanno, in Italia abbiamo assistito a questa esplosione di firme per la depenalizzazione dell'omicidio del consenziente, l'eutanasia, mentre c'è anche un disegno di legge sul suicidio assistito. Può quindi essere utile soffermarci un attimo sulle ragioni che ci hanno condotto in questa situazione, che hanno a che fare anche con lo sviluppo tecnologico, non per ovviamente criminalizzarlo, perché il problema è che ne facciamo noi della tecnologia. Da una parte abbiamo appunto sviluppi della medicina e di nuove tecnologie sempre più numerose ed efficaci, dall'altra dinamiche culturali che insistono sulla dimensione individuale della libertà, direi un iperindividualismo, inteso come autodeterminazione assoluta, nel senso latino absolutus, sciolto da tutto. Certamente ci sono degli elementi positivi in questa evoluzione. Siamo usciti anche da un paternalismo medico per approdare a un più equilibrato rapporto tra medico e paziente. Nel contempo non è facile trovare un giusto equilibrio tra questi diversi elementi e confrontarsi con pacatezza nel dibattito pubblico su questi temi effettivamente molto carichi di problemi delicatissimi. Come ha sottolineato Papa Francesco parlando ad un incontro che la PAV ebbe con la World Medical Association, Papa Francesco sottolineava la capacità terapeutica della medicina, cito, ci ha permesso questo di sconfiggere molte malattie, di migliorare la salute e prolungare il tempo della vita. Essa ha dunque svolto un ruolo molto positivo, ma per converso oggi è anche possibile protrarre la vita in condizioni che in passato non si potevano neppure immaginare. Per cui gli interventi sul corpo umano diventano sempre più efficaci, ma non sempre sono risolutivi. Possono sostenere funzioni biologiche divenute insufficienti o addirittura sostituirle. Chiusa la citazione. In questo caso non stiamo veramente promuovendo la salute. Occorre quindi un supplemento di saggezza, perché oggi è più insidiosa la tentazione di insistere, anche grazie alla disponibilità di mezzi tecnologici, con trattamenti che producono potenti effetti sul corpo, ma talora non giovano al bene integrale della persona. È per questo motivo, continua Papa Francesco, che è moralmente lecito, sto citando, rinunciare all'applicazione di mezzi terapeutici o sospenderli quando il loro impiego non corrisponde a quel criterio etico-umanistico definito proporzionalità delle cure. Tutto questo già con Pio XII era stato proposto dal Papa. L'aspetto peculiare di tale criterio è che prende in considerazione, e cito ancora, il risultato che ci si può aspettare tenuto conto delle condizioni dell'ammalato e delle sue forze fisiche e morali. Chiusa la citazione. Si consente quindi di giungere ad una decisione che si qualifica moralmente come rinuncia al cosiddetto accanimento terapeutico, che forse sarebbe meglio chiamare ostinazione irragionevole della terapia. È una scelta che assume responsabilmente il limite della condizione umana mortale, nel momento in cui prende atto di non poterlo più contrastare. Non si vuole così procurare la morte, si accetta di non poterla impedire, come specifica il Catechismo della Chiesa Cattolica. Questa differenza di prospettiva restituisce umanità all'accompagnamento del morire, senza aprire giustificazioni alla soppressione del vivere. Vediamo bene, infatti, che non attivare mezzi sproporzionati o sospendere l'uso equivale ad evitare questa ostinazione terapeutica, e cioè compiere un'azione che ha un significato etico completamente diverso dall'eutanasia, che ovviamente rimane sempre e comunque illecita, in quanto si propone di interrompere la vita procurando la morte. Il Magistero della Chiesa esclude quindi con chiarezza la legittimità delle scelte che sopprimono la vita, assistenza, eutanasia, assistenza al suicidio, ma si assume con altrettanta chiarezza la differenza tra uccidere e lasciar morire. Mentre il primo, nelle diverse forme in cui può configurarsi, è sempre illecito, il secondo è considerato lecito quando siamo in presenza di trattamenti appunto sproporzionati. Vale qui la pena di esaminare con più precisione quali siano gli elementi da considerare per giudicare tale proporzionalità. Ebbene, i piani da considerare sono due. Sul primo, che costituisce in realtà una sorta di premessa, hanno competenza i medici e riguarda l'accertamento dell'appropriatezza clinica delle cure. Il secondo dipende dalla persona malata, senza la cui valutazione non si può porre un giudizio di proporzionalità. A lei spetta la parola decisiva su ciò che concerne la propria salute e gli interventi medici sul proprio corpo. Saranno quindi necessarie un'informazione il più possibile completa, una comunicazione aperta, un dialogo collaborativo con l'equipe curante, ma anche con le persone care, con gli amici che accompagnano il malato. Queste considerazioni ci consentono di accennare anche alle disposizioni anticipate di trattamento, uno strumento valido che, per il rispetto della volontà del paziente nella valutazione di proporzionalità, che è il criterio fondamentale che legittima l'impiego dei mezzi terapeutici in medicina. Esse trovano la modalità concretamente più valida di attuazione nella pianificazione condivisa delle cure, e qui parlo per l'Italia, prevista dall'articolo 5 della legge 217 del 19, anche per l'insegnamento della Chiesa, come è scritto nella nuova carta degli operatori sanitari. Anche un impiego adeguato della terapia del dolore e delle cure palliative, che pongono una particolare attenzione alla persona nelle molteplici dimensioni che la caratterizzano, è molto importante per offrire una risposta ai bisogni del malato sul piano fisico, psicologico, relazionale e alle sue esigenze spirituali, evitando le conseguenze di un'assistenza inadeguata. Ma questo non toglie che la persona malata possa giungere a ritenere non sostenibili, nelle circostanze in cui si trova, trattamenti clinicamente appropriati. Il dialogo, il confronto e la consulenza etica possono aiutare a discernere e a decidere per un'opzione condivisa tra paziente, equipe curante e familiari. Per questo io vorrei soffermarmi un attimo sul significato dell'accompagnamento, anche di fronte a quello che abbiamo visto in questi tempi di pandemia, dove le morti sono state quasi doppiamente tragiche, perché prive di accompagnamento, perché prive di quel contesto che rendono umana anche la morte e non una questione della tecnica. Certe immagini non possiamo dimenticarle. Si tratta di una logica che presenta una sua precisa identità e che intende superare quella del controllo della morte, sia attraverso il tentativo di prolungare la vita a qualunque costo, sia ad accelerare o anticipare la morte. C'è come una doppia tentazione prometeica, quella di dare la morte o quella comunque di impedirla in ogni modo. Ecco perché la dimensione dell'accompagnamento, a mio avviso, è cruciale in questo tempo. Un attento confronto tra queste due logiche permette di rendersi conto che l'alternativa non è tanto tra accanimento terapeutico ed eutanasia, tra assolutizzazione della mera sopravvivenza e mitizzazione dell'autodeterminazione, che, come abbiamo visto, portano entrambe a esiti illeciti. In gioco ci sono due più generali interpretazioni della fase terminale. Da una parte, quella ispirata al controllo del morire, di cui, contrariamente a quello che si è portati a pensare, sia accanimento che eutanasia sono espressione. Dall'altra, quella ispirata appunto dall'accompagnamento. L'alternativa in ultima analisi dipende dal diverso significato che si attribuisce al tempo del morire. Come la banalizzazione della fase terminale, contro la banalizzazione della fase terminale, in fondo sottesa all'accanimento terapeutico, nella misura in cui questa pratica riduce il tempo umano a tempo biologico, e contro la svalorizzazione della fase terminale, in qualche modo sottesa all'eutanasia, nella misura in cui molti degli argomenti che la giustificano riducono il tempo umano alla sola durata suscettibile di controllo. L'etica dell'accompagnamento esprime un altro modo di guardare al tempo del morire che dobbiamo recuperare in questa nostra società. Di fronte alle situazioni che questo periodo di pandemia evoca, ognuno sa quanti argomenti e quante emozioni intervengono ad alimentare imbarazzo ed angoscia, e tuttavia non si può facilmente liquidare la questione, negando la particolarità umana della fase terminale della vita. E ognuna di essa è particolare. Non c'è nessuna morte uguale all'altra e non c'è nessuna disposizione che riguardi la fase terminale. Un bravo giurista piemontese diceva: ricordiamoci che di fronte alla fase ultima noi siamo sempre penultimi. Dissimulare questa particolarità sarebbe menzogna e ci porterebbe a minimizzare o a trascurare i particolari vissuti di chi si avvicina alla morte. Al contrario, valorizzare la fase terminale, come è nell'istanza originaria delle cure palliative, vuol dire introdurre il tempo del morire nel campo della relazione, per aiutare a viverlo nel senso che una persona intende dare al compimento della sua vita. Dobbiamo riscoprire anche l'ars moriendi. A questa basilare vocazione al prendersi cura occorre che la medicina dia nuovamente respiro, riconoscendone il valore. Occorre uscire dall'equivoco che intende palliativo come inutile o inefficace. Una confusione che appare dalle resistenze che di fatto ostacolano la pratica e la diffusione delle cure palliative, anche quando se ne afferma l'importanza in linea di principio, magari anche con la promulgazione di leggi che spesso rimangono inapplicate, come ad esempio quella che è in Italia. In Italia c'è una buona legge del tutto sconosciuta e non applicata. Di qui la richiesta di andare in Svizzera o di altre pratiche eutanasiche come quelle che pretende oggi il referendum. 1,5 milioni di firme in pochi mesi, moltissime di giovani, in un'ignoranza davvero preoccupante, un'ignoranza che è anche voluta, perché non è chiarita. La dizione del referendum, della dicitura, è di una, come dire, sottigliezza diabolica, per cui non voler soffrire diventa uguale a non vivere, a richiesta dell'eutanasia. L'esperienza clinica e didattica mostra che pochi studenti, sia di medicina sia dei corsi infermieristi, paiono intenzionati a dedicarsi alla cura della persona in prossimità della morte e soprattutto della persona anziana, considerando questo ambito professionale come scarsamente gratificato rispetto a specialità più ambite. Sabato ci sarà un convegno a Bologna, l'11 a Milano con i rettori delle università e l'anno prossimo l'Accademia ha preparato un convegno internazionale esattamente su questi temi, perché sono indispensabili per affrontare in maniera umana, assieme all'importanza delle nuove tecnologie, per rendere umana anche la morte. Le facoltà delle professioni sanitarie accentuano la preparazione per interventi sulle patologie acute e risulta difficile poi fare i conti con una medicina che, prolungando sempre di più la vita, prolunga il tempo di convivenza con la malattia. Viene qui alla luce una grande esigenza di sensibilizzazione e di formazione, perché crescono l'attenzione e le competenze per un'attività medica in cui molto può essere ancora esplorato e ricercato, anche per la continua evoluzione delle conoscenze e delle pratiche possibili. La formazione è molto importante, perché si tratta di andare oltre l'approccio teso a ripristinare il funzionamento di organi o apparati colpiti da malattia, che la medicina spontaneamente assume nel suo lavoro clinico. Invece occorre dare nuovo spazio alla relazione e all'ascolto delle emozioni che esprimono la dimensione propriamente umana del morire. Qui sta il problema che la cultura delle cure palliative è chiamata ad affrontare. Se non ne è capace, il rischio è che questo progetto, nato con l'intento di valorizzare personalmente e socialmente la fase finale della vita terrena e il passaggio a quella eterna, finisca per ridursi ad un'ulteriore forma di medicalizzazione del morire. In questo la telemedicina dovrà trovare un proprio equilibrio, perché il suo intervento non sarà automaticamente positivo, ma andrà governato con attenzione. È indispensabile una dimensione umanistica, come del resto in tutto il tema dell'intelligenza artificiale. L'altro giorno ho avuto un colloquio lungo con il nuovo vicepresidente dell'IBM esattamente su questi temi. L'anno scorso con il presidente di Microsoft, e l'ambito della medicina rientra nell'attenzione, come abbiamo visto precedentemente, ma non c'è dubbio che la dimensione umanistica ed etica è assolutamente indispensabile. Di solito la critica che si insinua quando si fa appello a questi aspetti del morire pone in dubbio la possibilità stessa di identificare dimensioni di portata e di valore universale. Mi avvio alla conclusione, scusate. Il concetto stesso di buona morte è criticato in quanto considerato da alcuni coercitivo. Però proprio la situazione che abbiamo vissuto e le emozioni suscitate dall'esperienza della morte al tempo della pandemia debbono mettere in crisi questi dubbi, questa critica. Proprio valorizzando queste emozioni, dandoci tempi e modi di farle risuonare dentro di noi, sia personalmente che collettivamente possiamo arrivare a riconoscere significati che favoriscono percorsi rispettosi della persona morente. Le emozioni a cui faccio riferimento sono quelle che abbiamo provato nelle fasi in cui le persone colpite dal virus sono state allontanate da casa e ricoverate nella terapia intensive senza poter più vedere i loro cari. Personalmente sono dovuto intervenire con il ministro Speranza per ben 2 volte per permettere ai familiari di poter visitare i loro cari in ospedale, e non è stato la prima volta inutile, la seconda volta parzialmente inefficaci. Non si muore solo di Covid, molti sono morti anche di solitudine. Io credo che prendere sul serio queste emozioni e istituzioni come quella di cui siamo ospiti, ma anche le altre istituzioni ospedaliere, debbono porre attenzione a questa prospettiva. Prendere sul serio queste emozioni ci mette di fronte a situazioni che tutti avvertiamo come non all'altezza della umana indegnità. Si parla di morte dignitosa, per molti significa morte subito. Non è questo il senso della dimensione umana, sia della morte che della dignità. Certo, si tratta di un approccio che consente in un contesto pluralistico come quello delle nostre società di far emergere le condizioni che ci aiutano in positivo a contribuire attivamente a predisporre le condizioni per una morte che rispetti la dignità delle persone. E proprio queste condizioni intendono favorire le cure palliative che mi permetto qui, in questo contesto, di poter, cercare alleati, visto che è una delle prospettive che la Pontificia Accademia intende perseguire con grande determinazione. Il riconoscimento di queste emozioni ci richiama al valore fondamentale della vita in ogni sua fase, compresa la fase terminale, collegandosi all'imperativo di superare la tentazione di una sua inutilità, anche perché ce l'hanno già detto per l'età anziana che è inutile. E se questa dimensione della inutilità data all'età anziana si prolunga, è ovvio che è meglio sopprimere che lasciar vivere persone che costano e non producono. La durezza con cui la recente pandemia si è abbattuta sulle persone, la brutalità con cui in molti casi le ha ridotte alla fase terminale, soffocandone la voce e bloccandone parole e gesti, ci confermano tragicamente la profondità di senso umano che caratterizza gli ultimi giorni di vita. Per questo le cure palliative sono nate proprio perché si riconosca questo tempo come un tempo importante della vita, a cui le nuove tecnologie digitali dovranno dare il loro preziosissimo e forse indispensabile contributo. Ci attende un grande compito, anche culturale, che comporta, da una parte, prendere pubblicamente posizione contro le pressioni di varia natura che spingono per ridurre il paziente in fase terminale a un insieme di funzioni biologiche inefficienti, da medicalizzare o da narcotizzare, e dall'altra di non svalutare il tempo del morire, ma di approfondirlo come un tempo importante per ogni persona e per l'intera comunità. Dobbiamo sentire la responsabilità, noi in particolare cristiani, che il tempo del morire è il tempo che ci permette il passaggio alla vita che verrà. La morte è un passaggio ed io confido che tutti noi cristiani comprendiamo quanto sia stato prezioso il tempo, quelle 3 ore sulla croce di Gesù, il tempo del morire, che ci hanno dato una nuova prospettiva non solo alla morte ma anche alla vita. Grazie per l'attenzione.
And now for the conclusions, I would like to give the floor to His Excellency, the Grand Hospitaller.
It's going to be very difficult for me to say a few closing remarks after what Monsignor Vaglia just told us, and we're very grateful that he was able to come to join us in this meeting. So according to the guidelines of the Ministry of Health in Italy, I quote, "Telemedicine means a method of providing healthcare services through the use of innovative technologies, and in particular, information and communication technologies, ICT, in situations in which the health professional and the patient are not on the same location. Telemedicine involves the secure transmission of medical information and data in the form of text, sound, images, or other forms monitored of the patients. Telemedicine services should be used for prevention, diagnosis, treatment, and subsequent all efforts to help the patients. They should be assimilated to any diagnostic therapeutic health service. However, the service in telemedicine does not replace the traditional health service in the personal doctor-patient relationship, but integrates it in the potentiality of improving efficiency, effectiveness, and appropriateness. And this fits completely with the position of the Order of Malta. Our approach is to meet each individual as a whole person, not just as a social or medical case or as a disease. We put the person first. Our holistic approach reaches out to our fellow man. We do not simply give medicine to heal, we care. We do not simply provide a lunch in our soup kitchens. We greet our guests and listen to them, to their problems and needs. If the body is in need, the soul and the mind is in need. If the soul and mind are in need, the body needs support too. These dimensions and realities are indivisible. And E-Health is an extraordinary chance to improve this approach and to better the patient-professional relation. New evidence suggests that care delivered via telemedicine can be both safe and effective, sometimes with better outcomes than conventional face-to-face care. Telemedicine services can also be cost-effective in different settings and contexts. However, despite these benefits, these services still represent a small fraction of all healthcare activity and spending. Important barriers to wider use remain, with providers and patients facing regulatory uncertainty, patchy financing and reimbursement, and vague governance. Due to the inequalities in health and digital illiteracy, patients that most stand to benefit are also often those that are least able to access and make use of telemedicine. Telemedicine has the potential to improve effectiveness, efficiency, and equality in healthcare, but can also introduce new risks and amplify existing inequalities. It's in this context that the Order of Malta is developing an e-program in spine surgery, including hand-on training at the Hospital of Fan in Dakar. Finally, I would sincerely thank all the relators who have shown the different needs and approaches for a more comprehensive understanding of e-health, M-health, and telemedicine. Experiences from Germany, Italy, and Lebanon in this field have been presented. How those technologies work and the revolution of the 5G. But as well, we have been introduced of the role of technology and also its use at the end of life. I thank all the participants, as well underlining that the Order is open to further discussions and to develop a strategy as a partner in an ethic, egalitarian, sustainable, and also charitable approach. Thank you very much. May I hand you the floor?
It's an honor, thank you. I would just again like to thank everybody for coming to this meeting today, and I wish you all a nice continuation of the day. Thank you very much. Bye-bye.